ABGs. I'm just bringing this up again because we do have people that weren't here in Block 2. You should have already learned ABGs. If you have a system and you are good at ABGs, leave it alone. You've got a system, go with it. Don't learn a new way. What I do want to point out is once you read it, we're going to talk a little bit about compensation. Our acid-base balance is controlled by two systems, our lungs and our kidneys. So if there's something wrong with our lungs, we will have an imbalance. And what system will help fix it? The kidneys. Yay. If we have something wrong with our kidneys, then our lungs will help fix it. That's all compensation is that there are two systems and one can help the other. Now, if both systems are effed up, maybe you got a COPD and renal failure, well, we're not going to be able to fix a problem. But what I want you to know is that the lung value is CO2 and the kidney value is bicarbonate. So when you're looking at a problem on your ABG, that will tell you the source of your problem. If the source of the problem is the CO2 level is way out of whack, then your problem is respiratory. If the source of your problem is kidney is bicarbonate, then it's probably metabolic and your kidneys are involved in dealing with that. So I'm going to show you, and so compensation just means that the other system has figured out there's a problem and is trying to fix it. Okay? Compensation just means that the other system is trying. It maybe fixed the problem, it maybe hasn't fixed the problem. You'll see fully compensated and partially compensated when you're doing these ABGs. The word partially compensated means the other systems realize there's a problem and it's trying, but it hadn't gotten there yet. If it's fully compensated, it means the other system threw itself out of whack to fix the problem. The problem being your pH. All your body cares about is the pH. It wants the pH between 7.35 and 7.45. If it is not compensated. If it's on its way there, it's compensated. Or if it's fixed, it's compensated. So you can have systems, and we'll talk about it, where your pH is right in between 7.35 and 7.45. But everything's all screwed up. That means that everything has gone out of whack to fix the pH. Okay? The whole body's fix is to fix the pH because cells die outside of that pH. So if our pH is too acidic or too alkaline, the cells will die of our body. Our cells only live in that pH range. So just like, if we put acid on something, it's going to burn. Our cells will die in acidic environments. So the body doesn't want its cells to die, so it will do amazing things to fix itself into that pH range. So it doesn't mean it's fixed the problem causing it, it means it's fixed the pH. Compensated means the pH is right, uncompensated means the pH is still not right. Okay, so let's look at a couple. I have a system that I like, but again, don't learn it if you have a system that works. I like this little grid. You can go in and brain dump it, and you just write your normals. But when you write your normals, reverse the CO2. Instead of writing 35 to 45, write 45 to 35. Respiratory values are reversed. The higher the CO2, the more acidic it is. CO2 is an acid. CO2 itself, carbon dioxide, is acidic. So the higher the level, the more acidic that value is. So if you have a CO2 of 60, that's acidic. That's super acidic. CO2 is an acid. So if that number is high, it goes to the acidic side. So I like to name it. I like to name things. I got a lot of kids. I got a lot of cats. I got a lot of rats. I got a lot of animals. We like to name things. So we start with last name, middle name, first name. The only thing you need for its last name is it only can have two last names. It can either be acidotic or alkalotic. And the only way, it doesn't tell you which side of the spectrum it is. Just look at 7.4. It's right smack in the middle. If it's on that side of 7.4, if it's on the 7.39 or below, or 7.44 and below, it's acidic. Okay? So anything 7.35 or 7.23, 7, anything other than less than 7.4 is acidic. Anything greater than 7.4 is alkalotic. Okay? So, I mean, that doesn't count if everything's normal. You just got a normal ABG. You don't need to name it. If it's normal, it's a normal ABG. But most of the ABGs I'm going to give you aren't going to be normal. They need a last name. So it's either acidosis or alkalosis. So you name it its last name. Okay, great. Then we got to figure out what its middle name, which one matches your pH. So I have a couple of examples in here, but we're going to figure out which one matches the pH, the CO2 or the bicarb. There's your problem right there. That's what's causing your problem, which one matches the pH. So if if you have an acidic pH and your CO2 is high, that's your problem right there. You've already named it. You don't need to go into a lot of it. And then the first name are the compensateds. Okay? And we'll look at these because it'll be easiest to look at them. So let's take one. So we dumped our little brain on the thing. We know what normal is. 735, 745, our CO2. Remember to write it reversed if you use this table form. Just do that. When you dump it onto your sheet for the test, if you use this table, just write 735 to 745, write 45 to 35, write 22 to 26, and then put them on their right columns. Okay? So for this one, 743, which side of 74 does it go to? The alkalosis side. So we write it on the alkalosis side at 743. The CO2, 31. It's on the alkalotic side too. Because remember, the higher it is, the more acidic it is. The lower it is, the more alkalotic it is. So you just know it's outside of 35 and it's on this side of 35, so put it in the alkalosis column. You don't even have to worry about the normal or abnormal. Where is the bicarb? It is on the acidic side. Okay, because it's 22 to 26, so we're going to put it on the acidic side. Which one matches the pH? So, what's its last name? Where is our pH? Alkalosis. You're like, but it's normal. Don't care. It's alkalosis because it's not a normal ABG. So we have to name it. If everything's in the normal column, you don't got to name it. You just call it normal. But if something's not in the normal column, then you got to name it. So we're going to name it alkalosis because that's what the pH is sitting. The middle name, which one matches it? It's respiratory. Hey, there's your problem right there. The middle name is the source of the problem. So we have a respiratory alkalosis. Now, did the other system recognize the problem and start to kick in? Yes. So it is fully compensated. What will the value be if it's fully compensated? The pH is within normal. It is. So we don't have to go any further. It's fully compensated. It's fully compensated respiratory alkalosis. We know it's fully compensated because this one's out of whack. The other system realized there's a problem and has gone to the other side to try and bring that pH in balance. And we know it brought the pH in balance because the pH is normal. So it worked. So we are fully compensated. Let's go on and try another one, rather than saying if. Let's go try another one. So where do we put our pH? It is acidic. It's on the low side of 7.4. So we're going to put it in acidic. What is the middle name? What matches? Well, let's just put the CO2 in a column. It's alkalosis because there's not a lot of it. And CO2 is an acid, so if there's not a lot of it, we're on the other side. We're on the alkalotic side. So our CO2 is alkalotic, and our bicarb is acidic. So which one matches your pH? You're metabolic because the pH is acidic. So this is the acidic number. So you have a metabolic acidosis. So now we got to look at it and say, did it fix it? Did the lungs fix it? We know the source of our problem is something metabolic because they are the one that match. Did the lungs try to fix it? Yes, they did. So did they fix it well enough? Is it within normal? Fully compensated. Okay, now we've got everything all over the place. Our pH, where is it? Alkalosis. Our CO2, is it low or high? It's normal, but we're going to put it on the alkalotic side of normal. It's still normal, but it's alkalosis. Metabolic is alkalosis. So we are everything on the alkalosis. Oh, what happened to the middle name? Dang it. Okay, we got alkalosis. We got that far. We said which one matches the pH. Well, they all match the pH. Which one's worse? The metabolic one is the one throwing us into it. Because this one's normal, alkalotic, but it's still normal. So could that one be causing the problem? That didn't send us that far into alkalosis. It's the metabolic side. Does that make sense? You don't look like it makes sense.
So I thought, okay, so the whole ROME acronym where it's
I hate ROME.
Oh.
But go ahead. Go ahead. No.
So yeah, so okay, metabolic's the same, so it would be the same anyway. So this
Correct.
would be right. Okay.
Yeah, because this, I mean, like I said, if you know ROME and ROME works for you, keep it. Okay. I never learned ROME. ROME confused me, so I threw it away. I made my own. But basically, which one is out of whack as the alkalotic value is the metabolic one. The metabolic one's wrong. So we're going to metabolic alkalosis. The source of the problem is metabolic. Yeah, and respiratory values are always reversed. I took kind of the ROME idea and just make sure that you write 45 to 35, and then you'll have everything on the right sides. But has the lung system figured out there's a problem yet? No, it's just hanging out doing its thing. It's got a normal value. It has not figured out that it's a problem yet. So the metabolic system is out of whack. Something's wrong somewhere metabolically making us alkalotic. But the respiratory system, if it was compensating, what would it be doing? It would be changing, and we are basically peeing out or losing, or something is happening to our positive anions. We are losing bicarb. Are we acidic or not? No. We are not acidic. Our whole body is very alkaline. So how do you think they would balance that? If we are very alkaline, what do you think the lungs want to hold on to? Acid to balance it out. So if the lungs are going to hold on to acid to balance it out, it's going to hold on to its only acid, which is CO2. And so that CO2 level would start going up to balance out our pH. But basically everything is abnormal, so we're only partially compensating, meaning that it hasn't even started trying. Oh, it's uncompensated. One value is still normal, because this one's still normal. So if this was over here at 48, that would be partial. Like the lungs realize there's a problem and starting to hold on to CO2, but it hadn't fixed the pH yet. That would be a partially compensated. This one's uncompensated because the lungs haven't done anything. They're just hanging out being normal. And they haven't figured out that there's a problem somewhere else in the system yet, and they haven't tried to fix the problem yet. Let's try one more. And you will have to go through a couple of these. I put that ABG Ninja up there because you can take whatever format you want, go through ABG Ninja, and just learn how to name them however you want. Once you learn how to name them, we're going to talk about what to do with them. So 732 on the acidic side. I don't care really if it's normal or abnormal at this point. It's on the acidic side. Our CO2 on the acidic side. Where's our bicarb? Way on the alkalosis side. Okay? So it is an acidosis. Which one matches it? Respiratory. It's a respiratory acidosis. And is it compensated? Partially. It's partially. The bicarb is starting to get messed up, but not messed up enough to fix your pH. Does that make sense? One system controls the bicarb, the bases. The other system kind of controls the acid. Now, we'll talk about what is happening in our body when this thing. So you just need to learn how to name it. And once you learn how to name it, you know what the problem is. If it's a metabolic acidosis, you'll know what the problem is. If it's a respiratory acidosis, you know what the problem is. So let's talk a little bit about that. And I will we will do more ABG practice in 104 if you need it. We'll talk about what you need. Let's talk about a respiratory acidosis. We're not talking about compensated or uncompensated. Okay, that's just a kind of a nice thing to know how long it's been going on. If it is uncompensated, it's just started. The other system hasn't figured it out yet. It's usually pretty fast. If it's something that's compensated, it's been going on for a long time. Does that make sense? Mm-hmm. That's pretty much all we use it for, is to tell how long has this been a problem. If it's been compensated, it's been happening for a long time. So let's talk about a respiratory acidosis. This is a respiratory problem. I'll give you that answer right there. Its answer is right there. Respiratory acidosis. This is a respiratory problem. The source of this problem is respiratory. we got to figure out what it is, but it's respiratory. You don't need to go looking any further. Go looking in the lungs. The problem is in the lungs. Our CO2, the cue is, we did an ABG. If we have an ABG, we can name it. If we don't have an ABG, what do you think is going on in the system that is respiratory acidosis? So we have a lot of CO2 in our bloodstream because it didn't get exhaled. We are supposed to get rid of it. We're supposed to breathe it out. There's too much CO2 hanging out in our lungs, and then it can't get out of the bloodstream. And so when we draw a gas, a blood gas, it's sitting there in the bloodstream. Do we want this acid in our bloodstream? No, it's supposed to be an exhale product. We're supposed to get rid of it. Why would we hold on to CO2? We are not breathing it out. It's trapped in there. Usually there are two problems: hypoventilation or obstruction. Okay? The CO2 can't get out. Maybe because there's so much mucus in there that it stays trapped in the bloodstream. We can't get that CO2 out. It stays in the bloodstream. Maybe you are not breathing enough to exhale that CO2. Those are really the only two causes of respiratory acidosis. So a patient that is weak and not breathing very well, they had too much morphine. Oh, they're breathing 8 times a minute. What do you think? Are they going to be retaining or blowing off CO2? They're breathing 8 times a minute. They're going to be retaining it. Let's talk about a COPDer who lives kind of acidotic anyway, right? Because they have a lot of secretions. So the CO2 can't get out. So let's say they have a pneumonia now. Now they have more secretions. That CO2 can't get out, and they become very acidotic very quickly. So usually there's only 2 causes: hypoventilation or obstruction. Okay? These things are examples of obstruction: COPD, pneumonia, atelectasis, having mucus in there, having junk, maybe an actual obstruction, like asthma, closing your airways. You can't exhale. Can't inhale either, but you can't exhale. Basically, anything obstructing your exhale can cause a respiratory acidosis. Anything that causes you to hypoventilate or have a low respiratory rate or not breathe in and out your total tidal volumes can cause respiratory acidosis. So now we know what the problem is. You don't have to second guess. Either you are given a gas or you know your patient's hypoventilating. So if I tell you your patient has COPD with pneumonia, what do you think you suspect is their problem? Well, it's a respiratory problem. And think about to yourself, is it obstructing my CO2 clearing? Then it's probably an acidosis. Okay? You don't need a lot more information than that. You either get an ABG or you get a respiratory problem with a lot of gunk that's preventing our exhale. So what do you think we're going to do for a respiratory problem? Of course we're going to monitor the respiratory rate, depth, breath sounds, pulse ox. We're going to sit them up because we want to clear whatever the hypoventilation or blockage is. So we need to look at the patient and say, did you get too much sedation? If so, we can reduce those causes. Maybe a patient is just exhausted from trying to breathe. We have an asthma patient that's been working so hard to breathe and inhale and exhale, and now their respiratory muscles are weak. And maybe they're breathing 14 times a minute, but their breath is... And they have accessory muscle use and they're hard to breathe. Would you consider that hypoventilation? They're not inhaling and exhaling clearly. So if the hypoventilation is due to muscle weakness, they may need some help breathing because that's the source of the problem. If they have an obstruction like mucus or cough or deep breathing or suctioning or something in the way or fluid, pulmonary edema, we need to remove whatever is causing all that junk in the lungs. Okay? 2 causes for respiratory acidosis: hypoventilation, obstruction. Look at your patient, figure out what the problem is, and there you go. You have fixed. We can fix respiratory problems pretty easily. It's the metabolic problems that are hard. Let's talk about alkalosis. We told the problem is respiratory, so it must start in the lungs. What would cause an alkalosis? Hyperventilation. Removing too much acid out of the lungs. We blew off all of our CO2. It's gone. There's hardly any CO2 left in our bloodstream, we've gotten rid of that acid, making us alkalotic. How do we get rid of too much CO2? Hyperventilation. Oh, wait, did I skip a slide? There it is. So, too much acidic CO2 blew off to hyperventilation. One problem for respiratory alkalosis. If you have respiratory alkalosis, they have hyperventilated for some reason. Don't overthink it. It's a respiratory problem. It's alkalosis. They've lost too much CO2. Why do you hyperventilate? You got to get to the bottom of why you're hyperventilating to fix the problem. Does that make sense? Why learn a bunch of signs and symptoms? But the thing is think about, have you ever hyperventilated? Go hyperventilate yourself. There's your signs and symptoms. But really what we're going to do, same assessments. It's a respiratory problem. We're going to watch the respiratory system. We're going to sit them up and stop them from hyperventilating. Okay? You're going to give them slow, deep breaths. You'll fix the source of the problem. What if it's fever and stress and pain? Give them pain. It's going to depend on why they're hyperventilating, but you want to fix the problem. Relax them, slow their breathing down. If they are hyperventilating because they can't breathe, you may end up having to give them CPAP, BiPAP to help them breathe better. Okay? So it really depends on what's going on in there, but the only problem that can cause respiratory alkalosis is hyperventilation. So figure out why they're hyperventilating and stop it. And then you will fix the respiratory alkalosis. Respiratory problems are great because we can intervene on them and try to fix them. So let's go to metabolic. This means the body's got a problem. Metabolic means the body has a problem. What is the body's problem?
Getting rid of bicarb.
There is some kind of problem, and we are acidotic in metabolic acidosis. So what are our acids that hang out in our bloodstream? Well, CO2 is our respiratory one. We've ruled that one out. So we can get rid of CO2. That's not a problem. Lactic acid, keto acids, anything with the word acid in it is acidic. And anything that is hydrogen ions, you know what are ions? You know all those little potassium with a little plus, calcium with a little plus. Anything with those little pluses on it are acidic ions. So if we have too much of an electrolyte, too much hydrogen, or we've lost our bicarb. So we either have too much acids in our body, or for some reason we've lost all our bicarb. I don't know how good you were at chemistry. I stunk at chemistry. But all you need to remember is that when we have a lot of acids in our bloodstream, we will use up our bicarb, because what acids and bicarb together form what? If we put an acid and a bicarb together, it forms water. Neutralizes those acids. So we have a lot of acids in our bloodstream. Let's say we worked out really hard, and you have a lot of lactic acid. What's going to happen to our bicarb level? We have a lot of lactic acid, and the body's like, oh, your pH is dropping. That bicarb will neutralize those lactic acids, turn them into water, but we will use up our bicarb doing that. And what makes bicarb? The kidneys kind of hang on to it for us. So our kidneys need to be working to regulate those levels. But we can lose bicarb from diarrhea, or our kidneys aren't reabsorbing it. So we don't know what the problem is. There's no one quick answer like there is for respiratory. Respiratory acidosis and alkalosis, it's a lung problem. We can probably see it. We can probably treat it. Metabolic will need to get to the root of an illness. It's a body illness, and we will have to get to the root of it. So if your patient is in diabetic ketoacidosis, they're going to be acidotic. If your patient's in renal failure, they're going to be acidotic. It may be something that we are just monitoring. They are septic, we end up in a lactic acidosis. So we will talk about these things as we go through the rest of the systems. I don't expect you to know what to do because we don't know yet. So you're going to monitor them and keep them safe and assist with identifying and treating the underlying cause. That's all we can do with metabolic acidosis. What do you think, if you could give one medicine, what would it be for a metabolic acidotic problem? Bicarb! Yay! We could give bicarb to this patient, and they may give bicarb to this patient. But it is a Band-Aid, it is a patch, It doesn't fix the underlying problem, which is whatever illness was making you do it in the first place. They will give bicarb, but I didn't put it up there because it's not the best idea. It's a Band-Aid, it's a patch, it covers up the problem, and you can ignore it for longer, but it doesn't fix the problem. Bicarb will be there to help you buffer acids and turn them into water, and will reduce the acid level, but you will continually produce acid until you fix the underlying problem.
Is that why you see a lot of renal patients
On bicarb, yes.
bicarb?
Yes, and that is appropriate. We'll talk about that in renal. Very appropriate with a renal patient, because the reason we're acidotic is because the kidneys can't reabsorb bicarb. So it's 100% appropriate for those patients to take bicarb. It's an electrolyte replacement. Yeah,
So then what else would we do?
that's it. Otherwise, you'd have to fix the illness. You'd have to fix the illness. So fix the diabetic ketoacidosis, we'll talk about that. Fix the lactic acidosis. Your body is producing lactate, it's because it doesn't have enough oxygen. If your body's producing lactate, and we'll talk about that when we talk about sepsis and illness and things like that, but we have to fix the problem.
So like if it stems from like just diarrhea and they're like electrolytes are all gone, so just stop the diarrhea and then rehydrate.
Exactly.
And fix them and
Stop
wait
the
for
diarrhea, rehydrate, and then everything should come back to normal. It takes a long time to fix a metabolic problem.
Like how long? Like weeks? Like
At least a couple of days, probably, if you're waiting for it. And sometimes they speed up the process with a little bit of bicarb. But remember, metabolic acidosis, you can give bicarb too. It's not inappropriate, but that's not usually the problem unless it's a kidney problem. If it's a kidney that can't reabsorb bicarb, that's your problem, and that's the underlying problem, and you give bicarb. But I'm not putting that in this interventions here because I want you to get to the bottom of the source of the problem. So if you have a metabolic acidosis, you are not done yet. You've got to figure out what's causing the acidosis and then fix that problem. So you would go, if you had a metabolic acidosis and your patient is sick and septic, then you would go find your septic card when you have the septic class, and you'll fix that problem. You'll end up fixing this one. Okay? Just know that bicarb is possible with metabolic acidosis, but we just give it symptomatically to help buffer things, but it doesn't fix the underlying problem. Acid will continue to either be retained or made or do whatever until you fix the problem. So the source of this one is going to be figuring out what your underlying illness is and then going to that problem card and fixing that illness. Okay? So if you are acidotic because you have diabetic ketoacidosis, you'll have to go to the diabetic ketoacidosis problem, fix that, and then this will fix in return. Okay? So do you think I'm going to ask you how to fix DKA? No, I'm not. You haven't had that class yet. So really, metabolic acidosis, the most I would want you to do is just figure out that it is an illness that is causing something and to figure out the cause of it. Does that make sense? Respiratory we can intervene on pretty quickly. Something wrong with the lungs, we can see, listen, feel. The other one's going to require a lot more investigation, and that's a collaborative effort. Metabolic alkalosis, I'm going to give you, what do you think is missing now? We retained too much acid or lost a lot of bicarb, making us acidotic. What do you think we've got a lot of here when we're metabolically alkalotic? We've got too much bicarb. Our bicarb level is sky high. So either we lost a bunch of acids, leaving bicarb hanging out with nothing to do, or we took too much bicarb. Either way, okay, there's two problems there. You kind of have to get to the bottom of it. We can lose a lot of acids by vomiting, NG suction, and diuretics, because what do those get rid of? Acids. Gets rid of your, stomach acids. It gets rid of, you got diarrhea. You pee out all your electrolytes. Remember, your electrolytes are acidic. So if we get rid of them all, then bicarb's left with nothing to do, and it's just hanging out there. Tons of bicarb. So the problem isn't so much the fact that we have too much bicarb. It's just like, hey, where do the acids go? So we got to kind of get to the bottom of that. I will point out that if the patient is vomiting or an NG suction, probably our first intervention, if we're losing acids that way, is to, hey, stop the vomiting or the NG suction. We could do that until we figure out more about what's going on. But since vomiting and NG suction is a real big cause of metabolic alkalosis and a loss of acid ions, let's stop it. So if we have that going on, I would say probably if you have NG suction, you could kind of clamp that and talk to the doctor about what's going on. You could possibly give nausea medicines if you have it to get the nausea, the vomiting to stop. If you have diarrhea medicines, you could give those to kind of get those to stop. If the patient, which we've had, just comes in, they took a whole bottle of Tums, well, they're going to be alkalotic for a while, and you probably just flush the system out. Their alkalosis really isn't going to do a whole heck of a lot for you, but you're going to still want to watch it. And if you lost a lot of electrolytes, keep an eye on your electrolytes. So really, I want you to think respiratory. If you have named it or think it's a respiratory problem, please fix the respiratory problem. This is an airway problem. Sit them up, do things to fix them. If they're holding on to too much CO2, it's either hypoventilation or hypoventilation or obstruction. Clear the obstruction, get them breathing better. For respiratory acidosis, they're holding on to too much CO2, get them breathing better. If it's respiratory alkalosis, we've blown off too much CO2 from hyperventilation, stop them from hyperventilating, whatever it is. Metabolic, we're going to need to get into some more detail. You'll probably need to notify the physician, but just know that one quick thing, acidosis we really can't do anything about. We have to treat the illness. Alkalosis, if it's from NG or vomiting, we can kind of get involved in that and stopping that. But otherwise, we still need to figure out what is going on. Metabolic problems are body problems, illness problems. They take longer to fix, and they need the help of the doc. We can't intervene right away. Does that make sense? Okay. So if I asked you stuff, usually